start, sir.
Okay.
Yeah.
Okay, I will start.
You can go live now.
Okay. Good afternoon, doctors. On behalf of Hitro Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctors, as you know, at Hitro, we market products in multiple therapy areas, like in gynecology, orthopedics, derma. We have strong R&D support and we have developed many unique formulations, keeping patient benefit in mind. Recently, we have introduced Carbetocin. Carbetocin, as you all know, is used for prophylactic management of PPH. PPH, we know, is a condition which can lead to disaster. While there are several papers and guidelines which suggest use of Carbetocin, we have eminent speakers to give us insights into their clinical experience with Carbetocin, which is more important to us. Today, we have Dr. Milind Shah to discuss and to tell us his clinical experience on Carbetocin. Dr. Milind Shah is MD, DGO, DFP, FICOG, FIAOG, Naval Maternity and Nursing Home Endoscopy and Infertility Clinic, Solapur and Mumbai. Sir is President, Indian Society of Perinatology and Reproductive Biology, 2016 to 18. Member, Maternal and Fetal Medical Committee of Asia Oceania Federation of OBGYN. Chairman, Safe Motherhood Subcommittee, IIM Maharashtra State. Founder, President of Infertility and High Risk Foundation. Founder, Secretary General, Federation of Asia Oceania Perinatal Societies. Deputy Secretary General, Indian Society of Aesthetic and Regenerative Gynecology. President, IMA. Vice President, Foxy. President-elect, ISPAT, 2019 to 21. Ex-Chairman, Rural Obstetrics Committee of Foxy, 2004 to 2008. Ex-Managing Committee Member, Indian Association of Gynecology Endoscopists, Indian Society of Assisted Reproduction, Indian Federation of Ultrasound in Medicine and Biology, Indian Medical Legal and Ethics Association, peer reviewer for Journal of OB/GY of India, past steering committee member, Asia Safe Abortion Partnership, professor and head of the Department of OB/GY, Gandhinatha Ash Medical College, visited many countries like USA, UK, Canada, France, etc., and all over India to deliver lectures on various topics in gynecology. Authored a book on hypertensive disorders in pregnancy, pelvic organ prolapse, and contributed more than 20 chapters in various books. Published many national and international scientific papers. Besides all this, sir is an active Rotarian, so amount of social work what he must be doing is unimaginable. Welcome once again, Dr. Milind Shah, to share your experience, and all over to you.
Thank you very much, Dr. Prashant. Yeah. Well, thank you very much, Dr. Prashant, for these kind words. It's indeed a pleasure to be part of this particular program because, as you all know, as OBGYN, it is always said as a bloody business because so many cases where we meet with a severe hemorrhage. And that's why I still remember our teachers used to say that when you want to become OBGYN, you should be ready to face the hemorrhage happening in front of you and you have to manage it very confidently. And in those days, you cannot believe, friends, we had a very limited actually sort of available oxytocin. Even prostaglandins were not very easily, rather not available when actually I started my practice in 1990 or somewhere around that. And that's why I feel very happy that now so many things are available in our armamentum and we can utilize them properly as well. And that's how actually we like to definitely say big thanks to the Hetero Pharma for giving this opportunity to discuss with you what actually is going to happen actually in the cases of PPH and how we can manage them effectively. Yeah. So my slides are seen to you.
Yes, sir.
Okay. And now I'm going to put them on the, the presentation mode. Let me see where it's going. Yeah. Yeah. Hopefully it has gone to the presentation mode. Now the full screen is seen.
Yes, sir. Yes, sir.
Yeah, great. And I'm really happy to have Prashant with us to moderate this particular session because all said and done, we know that whenever we are using certain things as a practice, we need to have a good support from our actually the other faculty actually members who can guide us on the various pharmacological actions of any particular drug. And that's why I'm really happy, Prashant, that we are going to discuss this very important molecule today with our friends from nearby district, and we are going to discuss something very important as far as the PPH is concerned. Because all said and done, people speak a lot about this definition of PPH, 500 ml and more than 1000 ml following seasonal section. But friends, quite often it is your clinical judgment which is most important, because in every case it is just impossible to actually see how much blood loss is happening, though there are so many parameters available. Like there are parameters available by which, by counting the sponges, by taking that actually blood which is lost during delivery or cesarean in a particular pouch. But all that is not actually practically feasible when it comes to in your own clinic. And that's why one need to think about this hemodynamic instability also is a very important functional definition of PPH, which is potential to produce the or produces the hemodynamic instability. That blood loss I call it as a PPH, and you know that it varies from person to person. For example, a woman may get actually the instability even by losing just 300 ml, and on the other end, there are some women, in spite of losing more than 1000 ml, they are absolutely clinically stable as well. But all said and done, one has to be very vigilant while dealing with these cases of PPH. And we have seen that 10 to 15% of all deliveries, that is 4% after vaginal and 6 to 8% of the after cesarean delivery, get postpartum hemorrhage. In India, the almost 25.6% maternal deaths are due to hemorrhage, and that's why one has to be very careful. When actually the heteropharma came to us asking about this particular webinar, they told me about the districts where we are going to address our OBGYN friends on this PPH issue. We have seen that these are the places where a lot of people they come from the rural area. Same is story with my actually Sholapur center, where we get cases from the interior of Karnataka, interior from Telangana, and also from the rural Maharashtra, where they have the lack of access to the skilled birth attendant who can administer the oxytocin. There's a high incidence of anemia, non-availability of safe blood, lack of refrigeration to storage the oxytocin, and lack of surgical expertise. And where our majority of the population lives, this is the story what we find there. That's why Mahatma Gandhi, when he said that go to villages, it is not very easy to go and practice in the villages when we have all these problems coming in front of us. I had been to many primary healthcare centers. I had been to many actually the camps for which I used to go for the lab ligation, and I used to see a lot of actually agony as far as this availability of various drugs as well as the storage facilities concerned. And that's why quite often it was not a surprise for me where I used to find the oxytocin kept at the room temperature, and I used to tell my all those medical officer friends that just see what is going to happen when you administer this oxytocin to your patient. Probability is as good as giving placebo because it is not stored properly. And that's why it is very important to tell them the all these facts and files about all these oxytocins which are available and how we can utilize them properly to understand what is going to happen. It's very important to see that the etiology is again very important, the tone, tissue, trauma, and thrombin in our mind while dealing with the PPH, because quite often people think about only first part, uterine anatomy, which is important, which is major, which is definitely preventable, which is manageable. But there are actually certain cases where the tissue which is retained in the uterine cavity, the trauma in the form of laceration, sometimes rupture and inversion, and the coagulopathy are all equally important. Two cases actually I distinctly remember and probably will like to know that one of our homeopathic actually the resident practicing at the very interior place called Kamti near Sholapur district got a case of inversion. But being a sincere student, he was knowing much about the inversion. And then he realized that I'm dealing with the death and the life. Immediately he took the patient, putting one sari wrapped around that particular inverted uterus, started IV line, and immediately brought the patient to my clinic. And to my surprise, that patient was, though hypotensive, we could manage her well. We could see that she becomes hemodynamically stable, and we could put the uterus back to its normal position. So that's why I feel that the knowledge is again very important, and because he was knowing about it, he didn't waste the time. Similar is the story of this coagulopathy. One of the lady had come from the Adan, that is again another interior place where the patient started bleeding, and patient then tells me that yes, in my first missed abortion also at the same story. And I said, oh my God, definitely it must be at the time of abortion she bled. So this time it must be again a very torrential bleeding. Eventually we managed, we gave a replacement and all those. And when we investigated, do you know what it turned to be? It is a case of severe hypofibrinogenemia, which is congenital condition and which is a very rare condition, but probably unless and until we diagnose them, we won't be able to manage it. So what is more important is, though we rely on the living ligatures which are there to support us by Mother Nature, we'll have to be ready for the prevention of this hemorrhage. We'll have to be ready to manage the hemorrhage whenever it happens in our labor room or in our operation room, and then we'll have to act very effectively. So these are the three cases again I'm going to share with you, that though it is very rare, but quite often we get, especially from certain communities where the family planning is not actually observed, or they say it is a sort of sin, where they come with the 10th, 11th gravida. And she had all FTNDs, few of them at home, few of them in the clinic, one abortion. She came in labor. She delivered and immediately started getting gush of bleeding in spite of our preventive approaches, where we need to work very effectively. But of course, that time, the newer actually oxytocin receptor agonists were not available. The another case where she was a twin pregnancy, where we delivered her by C-section, and after shifting to ward, she started bleeding with clots. Though again the all preventive approaches were done with the help of available WHO recommended oxytocins. But you know that always we need to think about the half lifetime of that particular molecule, and unless until we know about it, there's every probability that once the effect is vanished, uterus becomes flabby and starts bleeding as well, and probably must have happened the same in this particular given case where we need to work a lot. But the story, not only with the all those high risk cases, in some of the low risk cases also, we get sudden hemorrhage or hypotension after delivery. There may be a clots in the cavity with flabby uterus, and external bleeding may be comparatively less, but then we'll have to work very effectively to avoid all those untoward effects of severe hemorrhage. And that's why it's very, very important. So Prashant, I'm sure you must have faced the same situation when you were doing your graduation
Sir,
and post
yes,
graduation, your JJ hospital, where
sir,
there's a lot of patients they come for the delivery. Yeah.
I saw one case of PPH. I mean, I'm talking about a
Yes,
late 70s, and only thing available was oxytocin. You can imagine how
I
it
know.
was. I mean,
I
it was
know. Yeah, correct.
but the best thing of it was patient was saved.
Yes,
That was
that's
the best thing.
important.
That's
Yeah,
best
true.
thing. I mean, I can still visualize that situation.
Yeah,
I mean,
correct.
it's this PPH, as you rightly said, is good to discuss rather than see a patient.
Exactly.
Yes.
Correct.
Yes,
True.
sir, coming to this question. Now,
Yeah,
Carbetocin has been available around for quite some time. What is your clinical experience? Because to our doctors, your clinical experience matters much more than the guidelines.
true. Yeah, see, friends, actually, we could enjoy all that spectra of oxytocins. Means oxytocin, no doubt that every OB/GYN have used actually at every length and breadth, because it is available and very properly used oxytocins. But eventually, when the even prostaglandins came in the picture, I have seen the practice that some of our clinician friends used to use it as the first drug of choice, but that's not very correct, because every particular molecule has some or other untoward effects. But when the Carbetocin came to our rescue, I was immensely happy. Why? Because of the two reasons. The heat stable, as I told you. Because when we used to use actually the oxytocin, keeping that in the fridge and then bringing it back from fridge to the operation room or the labor room was a big challenge at times. Quite often, the electricity failure or the power failure is not very uncommon thing in the rural area, and then it becomes a challenge that whether that temperature has been really happening in the same way as we are expecting the refrigerator as well, because I have seen in some of the places. I remember once I went to Udagir, and there in that area the power shutdown is almost for 12 hours. So one need to definitely think about it. And the second thing, as I told you about the half lifetime, which is again a point of attraction for me, almost four times more than the
Okay.
oxytocin. So the whatever effect I want to have, especially in those large utera, was very beneficial, and that's how we started getting attracted using the Carbetocin.
Right, sir. Thank you. The next question is, what is that patient profile? I mean, we can anticipate PPH in any patient, as you rightly said, low risk patient or unexpected, expect the unexpected, as they say. But generally, where we anticipate PPH?
Yes. Yeah, very nice question. Very true, and very nicely you quoted as well, Prashant. Yes, every case is a challenge.
Correct.
So whenever we do the training of emergency obstetrics, not only in our state but also across the nation, we
Correct.
tell that whatever preventive strategies we'll have to use is for every patient. But yes, there are certain risk factors where we definitely find more chance of getting acute hemorrhage, especially whenever the uterus is, more actually enlarged, like cases of twin pregnancy, large babies. There's more probability of getting the hemorrhage. Similar is the story. Suppose there is a case of multipara where the babies itself are a little larger in the size. Additionally, uterus become flabby, and then those cases they are likely to bleed as well. As I told you, some of the cases where there is a coagulation defects, we'll have to identify them quite before, not like the patient where we met, where we diagnose that afterwards, after delivery. But by the time could have actually lost her life as well, which is very important. The cases where there is a contracted pelvis, one has to be very careful, because those are the cases where the chances of tear and hemorrhage is more.
Correct.
The cases where the deeply engaged head, again there is a probability, but here it could be because of the extension of the Caesarean scar here. So that one has to be very careful. So there are many such risk factors where we'll have to think about that the PPH is likely to happen, and accordingly we'll have to act very effectively as well. We always find that those cases need to be diagnosed well in advance, so that at least our preparation or the prevention is very apt. Nowadays, again, various factors are available. So suppose there is some actually defects in the clotting factors, we can very well make them available beforehand to avoid actually further complications. And all those risk factors need to be addressed accordingly.
So is hypertension or diabetes a risk factor for PPH?
Yes, those are the risk factors as well, because we all know that in those cases, there's every actually probability that the patient may bleed heavily as well,
Yes.
because of two reasons: the comorbidity which is there in that particular patient. Additionally, whatever drugs we are going to use for those particular conditions have some or other effect on the
Absolutely.
oxytocin receptor. So
And
we'll
these
have
days, there are
to
many young hypertensives, many young
yes,
diabetics.
correct. Yeah, very true.
When would you prefer Carbetocin over oxytocin? As you rightly said, oxytocin everyone has used. It's been our textbook brand, and it's easily
Yes.
available anywhere. So when specifically you would suggest to the doctors to prefer Carbetocin? All said and done, they would not prefer in all cases, but there are some cases where they should prefer Carbetocin.
Yes. Suppose someone asks me, as you know, sort of how they ask actually in that "Kaun Banega Crorepati" single answer, I would say that yes, the cases of multiple pregnancy.
Exactly.
What happens in multiple pregnancies, we need actually the sustained action and action for the longer duration.
Absolutely.
Because quite often what I have noticed in my clinical practice that those patients are managed very well on your labor table or quite often on the operation table
Correct.
because the anesthesiologists are actually the sisters, they give immediately oxytocin
Correct.
and they are happy. But once the patient is shifted to the ward or the room, they start feeling afterwards. And here comes the role of carbetocin, where we know that it is
Secondary
going to
PPH,
act for
right?
longer duration.
Yes, yes,
And
yes.
whatever effect we want to have for that particular pregnant uteri is going to be very, very penicillin. And similar is the cases where there is a where they have been already managed with the oxytocin with the induction or the augmentation.
Oh.
Again, there is every probability that the oxygen receptors are confused. And in those cases, the chances of PPH are more where we need the sustained action and we use the carbetocin.
In patients whom you know, where you know that the patient has got fibroid, would you suggest them to use carbetocin straight instead of
Yeah, fibroid is not the contraindication, so definitely we can use the carbetocin in those
carbetocin?
particular cases, and we can use them very effectively.
Can we use carbetocin in cases of retained placenta? Of course, we
Yeah.
saw this.
See, the studies have already shown that as it causes the sustained contraction the longer duration, we don't use it in the case of retained placenta.
Correct,
We
correct.
always start with the oxytocin as a drug of choice because we want to remove that placenta first.
Right, right.
Which is the priority. And once placenta is removed, we think about using carbetocin, similar like what we
Delivery.
apply the rule of for the methergine or the argometrin as well, where we know that the cervix should not get closed and the
Yeah.
placenta should not get written inside. That is what the concern we have.
Maybe a manual removal also may be required in some cases.
Yes, sometimes we need the manual removal.
Yes.
And that is another very important actually surgery in the obstetric gynecology because the many actually clinicians nowadays what I'm finding they come from the colleges which are have a very minimal load for the deliveries.
Oh,
For example, I know one medical college where they have a 16 resident and the
okay.
number of deliveries per month is hardly 30.
Oh,
So
wow.
they are not exposed to
Right,
do
right.
actually sufficient number of MRP cases.
Correct.
Whereby I remember in government medical colleges, the daily actually delivery load is 30 to 40.
Right, right.
So although the residents they get a chance one or other time or quite often more than that to remove the placenta
Correct.
and by doing MRP. And how to make your fist as a cautious fist is a lesson which has been taught very effectively by our postgraduate
Yes,
teachers.
seniors.
And
Yeah.
then how we introduce actually our hand in that flabby uterus without fear, and then how we grasp, insinuate our fingers between that plane, and how we take out that placenta outside. But once it comes out, then we'll have to immediately act with our actually oxytocin.
Absolutely.
And
Yes,
here
yes,
again,
yes.
the carbetocin is a wonderful choice because it definitely gives us a sustained contraction, and then the chances of getting patient excessive bleeding are very less.
Can we use carbetocin in Rh negative mothers? This question has been coming across India.
Yeah, true. Because quite often people think
Yes.
that whether it will cause any problem
Yes,
by
yes.
using the Rh negative mother, but it is like same other oxytocin. We can definitely
Correct.
use it in the Rh negative mother as well, and we can effectively use it.
Can we use carbetocin for prevention of PPH? In fact, we have already answered this. If oxytocin used for labor induction,
Yes, yeah.
yes.
Basically, oxytocin has a beauty that it can be utilized for the induction, it can be used for the augmentation, it can be used for the prevention, it can be used for the
Treatment also.
management of
Yes,
PPH as well.
treatment. Correct.
Yes, at present, the recommendation for the carbetocin is basically by the FIGO is for the prevention.
Prevention,
of
only
PPH,
prevention. Yes.
So these are the cases where we know that, as I told you, when we have used oxytocin beforehand for either augmentation or the induction of labor, again there is every probability that our oxytocin which we are going to use for the prevention may not act with full potential.
Right.
And in those cases, the addition of another oxytocin makes a major change for the uterine contraction, and that definitely prevents the excessive blood loss.
The next one. In which cases would you prefer IV route over IM route?
Yes, especially in cases where, as I told you, the chances of PPH are very common. In those cases, we use the IV route as well, and where we will have to see that that route is properly addressed. The IV line has to be very in proper fashion, and there should not be the extravasation of the any particular IV line, which the IV fluid which is going from that IV line, and then we can use it for the cases where there is over distended uterus, where sometimes we use the IV route as well over the intramuscular.
Sir, would you prefer IM route where you want a slightly longer duration of action, maybe a twin pregnancy? Because
Yes,
the duration of action would be a little longer than IV.
longer, yeah.
Yes.
The only thing, these are the cases where we need quick action because
Yes.
the action starts slightly
Later,
delayed with
slightly
the IM
slow.
route
Yes,
than
with
the IV
IM.
route.
Yes, correct.
So where we need the immediate action,
IV
we will
route.
correct. Very true, yes, yes.
If patient is not responding adequately, in fact, we got this question just now also. If patient is not responding adequately with carbetocin, what would be the additional uterotonics, or how would you?
Yeah, this is a very important question, Dr. Prashant, and I'm very happy that you put it in for the audience because I have seen that what people do nowadays, they have a fear. They want to avoid PPH, they want to save the patient, they don't want to, all those aftermaths of the excessive bleeding, and sometimes they get in hurry to use the all oxytocin simultaneously,
Correct.
or they use it in very large quantities because they don't want to get a chance. But we always tell to all our students as well as the clinician friends that there should be synergy in using the any particular oxytocin
Absolutely. Absolutely.
because it is not only that particular molecule, there are n number of factors. As I told you, the storage, the drug quality, the patient body response, all may differ from case to case, but in those cases we should give sufficient time for a particular molecule to act, and suppose it is not acting, then definitely you can use the further oxytocin. In cases of the where we don't find the result with carbetocin, the additional uterotonics definitely would be choice of prostaglandins, which we use and which works effectively to avoid the further hemorrhage.
Right. What are the advantages of carbetocin over oxytocin, which we already discussed? Misoprostol, carboprost, and methylargometrin.
Yeah. See, especially the all these actually prostaglandins definitely quite effective in the management of PPH, or they are very commonly used, but they have their actually own problems. Like especially all these oxytocin have some or other effect on the heart. The same is with the carbetocin, but comparatively prostaglandins, they can suddenly cause even myocardial infarction, which has been quoted in various literature or the case studies. So one has to be very careful on that particular cases. Similar is the story where actually there is a risk of asthma or bronchospasm with the prostaglandins, and that's
Prostaglandins.
why we always ask patients whether you have any respiratory difficulty before giving corbopras to understand about it. The methyl argometrin, in once upon a time, probably you must have seen that it was routinely seen in
Oh,
the
yeah.
textbook that it has given as a routine drug for the
Correct.
prevention of PPH by intramuscular injection when anterior shoulder appears actually on the perineum, because that was very commonly used remedy. Rather, it was the remedy used by the ancient people as well, because probably those who are not knowing, like there is a myth in rural Maharashtra. They use that one particular seed called gazga, where the
Uh,
girls play with those gazgas, na? So
uh,
it is argometrin, and they used to give the
okay.
crushed actually argometrin, that argot for the
Uh,
women actually after delivery to avoid hemorrhage. But
Acha.
eventually we learn all those problems because it causes severe peripheral vasoconstriction,
Mhm.
and that causes a lot of
Blood
problems.
pressure, yes.
And yeah, blood
Yeah.
pressure, and it can cause the preload which increases suddenly on the heart, where the heart is already compromised because of the altered physiology during pregnancy, and then it can cause sudden failure as well. That's why thinking of this peripheral resistance, it has become a second line of choice.
Correct. Correct.
Though it has not lost is actually the position in the practice of obstetrics, because it also gives a very wonderful result as far as uterine contraction is concerned. But again, one has to be very careful that entire placenta has to be out because it causes suddenly it's sort of, tetanic contraction and the cervix gets closed. So one has to be very sure when you are dealing with the case of PPH, there is nothing in the uterine cavity, and then you can use that particular molecule. But the carbetocin gives all those benefits over all these other, actually the oxytocins, where we can achieve the good result for longer duration and with comparatively more safety as well, as far as the use is concerned.
Should carbetocin be kept as a reserve drug or it should be used as a first line?
Yeah, again, a very important question. Uh, some of the clinicians will not agree to use as a first line because naturally it is because of the experience. For example, when carbetocin came, almost it took me for a year to accept that it has to be used very commonly than I was thought about, because we were getting good result with oxytocin and we had actually the wonderful storage facility and we were vigilant and staff is also was vigilant as far as the storage is concerned. But same rule cannot be applied to the all clinics or the all PSCs and the cottage hospitals where they have their own limitations. I mean, though the doctors are knowing about it, they want to do it, the staff nurses also want to do it, there may be limitations of having the good refrigerators, acting refrigerators, getting the power supply
Yeah, power
continuously
outage
is
is,
a
I
big
mean, in Mumbai
challenge.
also it happens these days.
Yes.
Yeah.
So in those setup, probably carbetocin could be the great actually to be used as a first line acute treatment. And I'm very sure that now the FIGO, WHO all have agreed on this particular fact as well, where they understood about the heat stability. That heat stability and the prolonged action is going to go a long way as well. So it may become as a first line eventually over time. But till right now, the WHO recommends the use of
Yes.
oxytocin as the first line. But the things may change as more and papers will get published and we can understand more about it.
And as you had said already, that the ease of use also matters for carbetocin.
Yes,
Single dose
yes,
can be given IM without a drip. I mean, the interiors especially it matters. We have seen the facilities
correct.
there. We have seen how difficult it is.
Yes,
How do you
yes.
compare adverse effects, contraindications of carbetocin over oxytocin and other deuteronics? So, have you seen this ADH-related effect with carbetocin? How common it is or how rare it is?
Yes, to my fortune, I have not seen any ADH actually
Okay.
the cases when I use the carbetocin, but it is again having the same thing in
Yeah.
cases of high blood pressure,
Hmm.
where the heart is compromised. We'll have to be very careful while
Right.
using this particular drug, and those cases need to be managed very effectively at tertiary level care center because there is every probability that
Yeah.
whatever drug you are going to use may cause some untoward effect as well.
Right.
So one has to be very careful. But per se, there's very less actually the side effects. Few of the patients they may get slight nausea and little uneasy feeling, but otherwise I have not noticed any much of the side effects with carbetocin.
How would you conclude efficacy, safety, tolerability? In fact, a take-home message vis-a-vis other
Yeah.
deuteronics.
Yes, yeah. Wonderful. But before that, I think I must say big thanks to Dr. Prashant for wonderful actually the questions as well as the good discussion
Sir,
about
it's
this particular
exactly.
molecule.
And it is this discussion which matters to our doctors, your clinical insights, more than the
Exactly.
guidelines.
Yes, yes. So basically, friends, we'll have to be very careful while using any particular oxytocin. Though we have now these four actually elements available with us for the use of prevention as well as the management of PPH. And of course, the surgical approach also has expanded a lot with not only obstetric hysterectomy but a lot of conservative procedures available with us. Always tell that our actually clinicians should get uh, acquainted with all those techniques over time or due time. But what matters is your confidence. For example, whenever I find young OBGYNs, they want to deal with the case of PPH where need to be managed surgically, and if they are well versed with the obstetric hysterectomy, I tell them that yeah, you go ahead because that life is more important rather
Absolutely,
than
absolutely.
trying with the systemic devascularization, which is again a wonderful tool. But they may not be confident as well because they are not yet getting exposed, and the case may get more deteriorated, may go into coagulopathy
Complication, yeah.
by the time they will try with this systemic devascularization. Similarly, the story with the use of oxytocin. I only tell them that don't put everything in one basket. Don't
Correct,
immediately put
correct,
all
correct.
the drug in the patient's body, and probably will be then dealing with not only with the uterine atony, but all those untoward effects of those various oxytocids.
Correct.
Use it in very systematic fashion, one after other. If one is not working, second will be for your rescue. And that approach, when we apply with good confidence, good communication, good documentation, definitely you can conquer actually the PPH or the hemorrhage very effectively, and that fear will get elevated over time as far as the delivery
With
or the
experience,
cesarean
yes,
and its
yes,
hemorrhage
yes,
is
yes, yes.
concerned, which is very very important. Because gone are the days where we used to rely only on the certain molecules cell, but now the armamentum has increased, and even the personnel have increased, and that's why one has to be very very important.
Correct.
That's why when I say thanks, I always and always tell about this story of Mumtaj, which is not very new to our OBGYN trends. But I still remember the one sentence in that history book that when she got severe hemorrhage in her 14th delivery, so many Veds were, those practitioners, they were used to call Ved or the Hakims. They were summoned to manage her. And being a king and queen, there's no dearth of calling the
Yeah, yeah, yeah.
people, but still we could not save her. And what we got,
Unfortunately,
though
yes.
beautiful monument, there are always tears behind
Yeah,
that
yeah, yeah,
monument.
yeah, yeah,
That
correct, very
yes,
correct.
is because of the loss of a woman due to PPH. So one has to be very careful to see that while dealing with any case of obstetrics, one should not lose the life because of the hemorrhage.
Right,
We'll
right.
have to be very careful. Don't think much about the your personal actually the egos and everything. When call the people for the
Yeah,
help,
yeah, yeah, correct.
because in all those training programs we tell the help as the first thing, where you can call your sisters, you can call your colleagues who are OBGYNs or the maybe general practitioners, and they can help a lot.
Everyone, yes.
Because in those cases the
Saving life,
multidisciplinary
yes.
approach and the many people suppose they work together, we call it the mega code, we definitely are able to manage that particular case effectively
Much better.
without losing the life. Thank you very much.
Thank you, sir. Thank you very much. It was wonderful. I got a lot of insights myself. The importance of the fibrinopathies. I mean, I was not aware of this. How important
Thank
it
you
is.
very much.
Yes, sir.
Thank you. It was indeed pleasure, and thanks
Yes,
to Etoro Pharma as well for this opportunity to speak with our
yes, sir.
friends. Previously, I was thinking that there will be more people who will be coming and joining and sharing their experiences, but I'm sure this is also a good approach where
Yes,
we
yes,
can
yes.
spread our
Experience,
things
yes, sir.
and experiences. Thank you
And
very
thanks
much.
all the doctors for taking out time and attending this webinar. Thank you so much. Thanks marketing team Hitro for conceptualizing and putting this in place. Thanks IT team Hitro for your IT support. And thank you very much Field Source of Hitro for your active support, without which this would not have been possible. Thanks all of you once again, and signing off. Thank you, sir, once again. It was a pleasure
Thank you.
discussing with you.
Yeah,
Thank you.
same here. Priyanka, are there any questions in the chat box?
No,
Nothing.
sir. Only one question
Okay.
it was answered by you.
Answered. Yeah.
Yeah,
Okay.
it was that
Good.
if
Thank you.
Carbetocin doesn't work,
Okay.
that was
Yes.
the
Yes.
question. Yeah.
Thank you. Thank you
Thank
very
you, sir.
much.
Thank you.
Thank you.
Thank you. Okay. Good. Yeah. Thank you. Priyanka, thank you very much for your perseverance. In fact, that is most important. Otherwise, sometimes in hush hush of practice, you forget, and
Yeah, yeah,
that
yeah.
is
Yes, sir.